we are having with us Dr. Mohideen Abdul Kadar sir, who is going to give us some tips to be followed for gonioscopy. That's again one of the, I would say that is the best friend in your glaucoma clinics. Gonioscopy, you cannot shy away from gonioscopy if you are assessing a glaucoma patient.
Yeah. Okay now. Yeah. I think gonioscopy is the third one. Like we do a night examination, then appellation, then the gonioscopy is the third one. So the gonioscopy, let's see how. Just give a small case scenario. For 17 years boy, history of Kadar surgery for trauma,
they are not able to sit.
A person with computer defective is a light eye since 4 months. Then he came with a vision of 660 right eye and 6/6 left eye, and this corresponding to near vision in 36. So it's a clear cornea, deep chamber, and PCO thick next PCO. One is normal, ICAR is 18. So left is normal. So he underwent a AIOC capsulotomy, and around 1.2 millijoules for 36 hours because of they put him on moxifloxacin and dexamethasone 6 times a day, and astaxanthin given 1 BD for 3 days, and he was asked to go. But he proceeded 3 hours later to the vision center. This comes with severe eye pain and associated headaches. And epidural edema processed 15 in 3 hours of capsulotomy, and they started diamox and they referred to the base hospital again. So he was admitted and gave to IV mannitol, acetazolamide. Still was continued. They started a cyclopathy of macular glaucoma. So day 2 they referred us for glaucoma clinic of opinion. So this is a typical case of an epidural edema and Flaren's cells 1+. PCOL and AIOC2023 in the PC opening. So what do you want to do? I told my, look at the gonio. So gonioscopy clearly says what the diagnosis. I think the angle recession. I think the C360 angle recession he had, so, but he didn't have a pressure hike before the capsulotomy. He still responded. So when he stopped steroids, then within 1 or 2 days the pressure came down to normal. So I think gonioscopy is important fundamental part of any comprehensive examination. The basic purpose is to determine the top of the anti-chamber angle. So what are the landmarks you see? You see a solid-based line which is more anterior. Then you have trabecular measure, you have pigmented and non-pigmented one. They have slums canals deeper to the trabecular measure. You have ciliary spur, and you have ciliary body and iris processes. So this is a typical gonioscopy find. You see solid-based line which is the pigmented line. Then you see a trabecular measure, non-pigmented, then pigmented. Then you see ciliary spur. Then see this is the order normally we see in an angle. So slums are normally not visible because like deeper to the posterior trabecular measure. Whenever you put too much of corneal pressure, cutting a fistula, Sturgeon syndrome, venous hypertrophy, you can see a blood in slums canal. So what normally this is the classification that we follow the safer system based on the angle of the angle basis. Normally we say grade 0, 1, 2. We normally they will say the 2 is an occluded angle, the 1, 0, 1 is the closed one, and 3 and 4 the normal one. Normally we say depend on the angle width. The angle with more than 3 we say or more than 20 to 35 degree, and 4 is 35 to 45 degree. And this is a typical diagramic book is given, the grade 0 and 1. See the grade 0, you know that the angle wedge doesn't meet. When the two wedges meet, they correspond to the solid-based line. So this is the way normally we all of us will follow. What is slit angle? The no obvious vertical contact, but the no angles are identified. Slit angle, extremely high closure cases. Okay. What directly we see in the entire gonioscopy, we use a slit lamp. We have two techniques: one is indentation, not without indentation. And what are the lenses we use? A Goldman 2 mirror, a single mirror, or you use 4 mirror, post panel, 4 mirrors. What are the difference between 2 mirror and 4 mirror? A 2 mirror, the central wall is center is 12 millimeter, the convex is 12 millimeter, and the mirrors inclined 62 degree, especially in a 2 mirror, 64 in a 4 mirror, and the radius of inner surface is 7.4 in a 2 mirror, and here is 7.7 is equal to cornea. So this allows the tears to use the cupping solution. So what are the artifacts you avoid? You try to make a small slit beam, 2 to 3 millimeter, avoiding to the center of the car people because you can avoid less transection, pubic transection, less illumination. Use a Goldman 2 mirror, try to avoid indenting peripheral cornea. If you're using a size 4 mirror or a Sussman or Postner, avoid pressing to the central cornea in order to avoid the angle. So what is the plateau iris? Typically you see a double is like Double hump pattern, basically an anterior portion ciliary process which causes the peripheral to the ankle, the plateau iris. The plateau iris, along with dilatation, causes high pressure. After PI, we say plateau iris syndrome. So this is typical of creeping ankle glaucoma. See, typically it looks like a mimic like an open angle glaucoma. Unless you do gonioscopy, see one part of the ankle is open and one part of the ankle is closed. This is like a zip. Unless it is very difficult to find out. And the ankle neovascles, which is external angle to the solid spur, otherwise with double claw measure, they are fine and they are superficial, branching and unseen. And what is sacral dialysis? Normally this is considered for a spur. It directly you see a sclera, a deep angle, hypotomy and white color of the ankle. So what is the indentation gonioscopy going to help you find? So look at the figure 1. The angle is closed. You try to push the lens, indentate. What happens? Angle opens. So what we'll say? It gets an opposite angle closure. Okay. The figure number 3. You push again, but the angle doesn't open. The sinic is there. It's a sinic line closure. Figure number 4. You push again, but angle is little opening, but not enough. See, look at the lens thickness of the angle. The figure 4. The more thicker anteroposterior lens thickness. The culprit is the lens. Here, the scenario 4, you have to remove the lens. The scenario 1 and 2 and 3, you do the RPA. So, depending upon the mechanism, give you the mechanism of what the cause of an ankylosing glaucoma. We just see an indentation gonioscopy video. This is a case of a narrow angle with a PXM. And see the Van Herix they want to do. Then what we do, we just look at the angle. We try to indent. See, we're trying to indent. See, the indent, you can able to see a couple of mesh work, and that means that in the case of an oppositional closure, and this definitely need an RPA. Look at the plateau iris. This is typical of double hump pattern. See the one hump to the mid periphery, the one hump near the angle recess. This is typical of a plateau iris syndrome. So this definitely need mostly the diagnosis after RPA. Okay, mostly done after RPA. So when you dilate, some pressure goes up. And next we'll see this plateau iris syndrome, and next the creeping again. So I tell you, so one area is closed. See this area, what you see is the pigmented solid base line, and this is the pigmented double claw measure. So if you use a corneal wedge, you definitely know which is the pigmentation of solid base line, which is the double claw measure. The corneal wedge is very important, especially in narrow angle. So you see a two demarcation. The one angle is closed and one angle is. This is a typical of case of a creeping ankle glaucoma. Normally it is missed unless you do a gonioscopy. It's very important, especially to prevent malignant glaucoma. This is a patchy tuft. Sometimes you get a subacute attack. So you get something like a patchy pigmentations. This is a typical case of subacute ankylosing glaucoma. Definitely this kind of cases the need an RPA. Then you also see a pigmented angle. Sometimes you see a lot of pigmentation angle. You see a lot of pigmentation angle. Sometimes in a pigmented glaucoma, sometimes even if doing some diabetes patient, semi-peaks of glaucoma, it's a pigmented angle.
So if you can please point us.
Yeah. So just mentioning how to clean the gonial lenses. Normally we use an 70% alcohol sponges, and along with the chlorhexidine is available. So just first you clean the lenses with the alcohol sponges. After that, you clean with your normal sterile cotton. You can directly do with a non-alcohol sponge. You can harm the cornea. So again, you just clean the one. You don't clean it. There's a lot of chance of adrenal conjunctivitis. So also, alternately, you can also use 1 to 10% of household bleach sodium hypochlorite. You just fix 5 minutes. So just put a few solution, especially for the 2 meter, back then beam to 2 to 3 millimeter. Ask the patient look up, and know all the patients will be cooperative. We explain to them properly before the procedures. All the patients will be cooperative. None of the patients say uncooperative. So I just this is the 2 meter. Again, the 4 meter we can. After the seeing a superior and inferior mirror, just rotate, look at the nasal and inferior mirror. So again, you can just use it for even for 4 meter. 4 meter doesn't need coupling solution. You just need to directly and gonioscopy can be very important, especially as a lookup and just closing. So you can also especially for GAD, the gonioscopy can be very important because we need to look at this angle and go there and look at the angle, look at the pigmented double claw measure, make a nick there, then you see a slump canal. Okay, then you see a slump canal, you deepen that area. See, you see a slab canal, then you put a suture there. This is slab canal. So once you
Thank you very much.
yeah.
The presentation is
Yeah, so to conclude, I think first thing you need to buy your own Gonial lens. That is very important. And this is a part of comprehensive examination. You do at least 100 Gonioscopy examination before you say which is abnormal. I say Gonioscopy is an art. Thank you.
Thank you very much.